Satyajit and Pooja's opportunity. I am not much of a corneal surgeon myself, a pediatric ophthalmologist and a public health specialist. But since I am the first speaker, I'll just present 2 slides on what OCT is and how, as Dr. Pooja said, it has really revolutionized the way we are looking at the anterior segment and the posterior segment. When the OCT was first thought out as a high-resolution cross-sectional imaging modality, it was initially developed for retinal imaging because it looks at a very thin structure. The anterior segment being almost 4 millimeters, 3.5 to 4 millimeters in depth, was initially first not thought of, though of course in 1994, Izzat et al. Used the same wavelength, that is 830 nanometers for anterior segment OCT. But because of the reflections from the cornea, this wavelength was not found to be suitable, and that is when a longer wavelength of 1310 nanometers was developed, and this had the advantage of better penetration through sclera as well as real-time imaging of 8 frames per second. We have of course the time domain OCTs and the newer spectral domain OCTs. The SLOCT by Heidelberg Engineering and the Visante by Carl Zeiss Meditech are the 2 most common ones. And now of course we have the Corneal domain OCT technology that has come into being. But one thing that has really made OCT the technique of choice are 2 things. One is that it is non-invasive, and second, it is non-contact. So in patients who have had injuries, in patients who are unconscious, in little children, uncooperative patients, we can still use this where other techniques would not be possible. Some people say yes, what a good slit lamp examination and a gonioscopy will tell you, the OCT may tell us the same thing, but it can tell us so much more, and it can tell us in people who cannot be made to sit on a slit lamp. And of course, it can also be seen by people like me who are not that good at doing gonioscopy and perhaps finding out the small angle recessions of foreign bodies. Now the Visant OCT has several scanning protocols in which the enhanced anterior segment single scan and the high resolution raw scans are the most useful. Since there is going to be a separate talk on the glaucoma part of it, I will not elaborate in this. But here of course we have both the qualitative and the quantitative assessment that is there in the OCT. Like in the qualitative, we can find out, yes, that this angle is narrow. But in the quantitative one, we can actually enumerate what is the angle opening distance, what is the angle recess area, or what is the trabecular space area. All of this can actually be calculated and put forth. So if we are looking at a patient who say a trab leb we are managing, or a post-op this we are taking, or a shallow anterior chamber that is there, we can actually over the weeks actually have an objective evidence which our good slit lamp examination or even a gonioscopy or a goniophotography will not give us. So we know it is used in glaucoma practice as an adjunct to gonioscopy or as a substitute where gonioscopy is not feasible. It is useful extremely as a patient education tool because you have a picture that you can show to the patient, especially when a laser peripheral iridectomy is to be recommended. So you can show him the pre-iridotomy picture and the post-iridotomy picture. And of course, it is non-contact and can be performed even under dark conditions where the angle will be still physiologically stable and there is physiological mydriasis. So we can have a normal versus a narrow angle that's seen over here. Even in cases of Descemet's breaks or foreign body, this is where an OCT can give us a very clear-cut picture, much better than what a slit lamp image would show, and something that we can tell a patient. So as a patient education tool, it is extremely important. Even when we are doing intacts, for showing intacts channels, for showing iridectomies or iridotomies, or even in cataract surgery where there has been iridodialysis and we want to track that, even that can be done with a OCT. Most importantly, if there is a corneal infiltrate and an ulceration, and even in urban areas, even though bacterial keratitis and fungal keratitis are nowadays rare, they are still sight-threatening conditions in rural areas or in many parts. And here again we have an objective evidence as to how our treatment is going. So microbiological testing and all have their own place, and of course, but this is an adjunct that was not available till a few years ago. Post-cataract surgery, if there is a resolving corneal edema, even that can be mapped. Post-keratoplasty, if we are looking at the graft-host junction and how that is taking place, and if there is an early chance of rejection, even that can be seen on anterior segment OCT. And of course, if there is a foreign body, this is a foreign body we see on the cornea, but upside at 9 o'clock there is a foreign body even at the angle, which can be very easily seen in an OCT. And angle foreign bodies can be seen and they can be planned and removed. One thing before I conclude is, there is of course the UBM that is there. So in what ways would an anterior segment OCT be better than a UBM? Well, in anterior segment OCT, the technology is optical, while in UBM, it would be ultrasound. The resolution would be at 15 microns compared to 50 microns in a UBM. But then the biggest advantage is there is no contact with the eye in the anterior segment OCT, unlike in the UBM. When the ultrasound probe, even if it does not directly contact, it requires an immersion bath. There is a real-time imaging in both of them. The UBM definitely is better if we want to look at structures behind the iris. The anterior segment OCT cannot help us do that. And of course, for quantitative measurement, when we want to look at angles, when we want to look at the space that is there, they are both equally good. But again, an anterior segment OCT, as this with a posterior segment OCT, can give us a complete picture which a UBM will not be able to do. Thank you.